Good afternoon, everyone. I am Dr. John Michael Lau. I'll be talking about liver function tests, neonatal jaundice, and viral hepatitis. And these are the learning outcomes for our lecture for today. So, given a clinical case involving a liver disorder, decide what is the appropriate liver function test to order, interpret the liver function test results, predict the possible liver and or biliary tract disorder basing on the liver function test results, and correlate, of course, the history and PE findings with the liver function test results. Second, given a clinical case involving jaundice, especially neonatal jaundice, interpret the bilirubin test results, trace the pathophysiology of hyperbilirubinemia, and discuss the hereditary disorders of bilirubin metabolism. Third, given a clinical case involving viral hepatitis, discern the possible type of viral hepatitis based on the history and PE. Interpret the hepatitis viral markers results. Okay, so that will involve the nucleic acid, the antigen, and the antibody, and the identify which phase of chronic hepatitis B basing on the viral markers and liver enzymes. Okay, so let's go first to liver function tests. So the following are the liver function tests that we'll be talking about. So let's go first to this case. A previously healthy 38-year-old woman has become increasingly obtunded in the past 4 days. Upon physical examination, she has scleral icterus, abdominal fluid wave, that is ascites, and asterexis. Okay, that is a flapping tremor. Okay, she is febrile and her blood pressure is 110/55. Laboratory findings show prothrombin time of 38 seconds. That means that's prolonged. Okay, an international normalized ratio 3.1. The normal is 1:2. Okay, and serum ALT of 1854, that is way elevated. AST of 1621, that is way elevated also. Albumin of 1.8, that is decreased, and the total protein of 4.8. What serum blood level will most likely be abnormal in this patient? So take note, the patient has asterexis. Okay, and it's increasingly obtunded. Okay, so the first thing that will come into your mind is, so the patient has most likely patient already had cirrhosis. Okay, if you have listened to our GenPath lecture. Okay, so what could have caused this asterexis? It's ammonia, and the disease and the complication here involved is ammonia or hepatic encephalopathy. So this is the continuum of liver injury. Okay, so you have normal liver developing to a fatty liver, hepatitis, cirrhosis, then cancer. Okay, and these are the liver function tests. Okay, I got this from our GenPath book. Okay, Robbins. And these are the different types. The first is the one that will the ones that will evaluate hepatocyte integrity, the membrane. Okay, so we have the AST, ALT, and LDH. So these are the enzymes that leak out of the hepatocyte when the hepatocyte cell membrane as well as the mitochondrial membrane gets damaged secondary to injury. Second is biliary excretory function. Okay, again, these are enzymes. So I'm pertaining to these. Okay, we have alkaline phosphatase, GGT, and nucleotidase. Okay, that leak out of the damaged biliary epithelium. Okay, we also have bilirubin. Okay, for example, there is obstruction. Okay, you will have increase in bilirubin. Okay, for example, if there is a hemolysis, you have increased bilirubin also. Next is you have hepatocyte function. Okay, so among these three, this one, hepatocyte function, is the real liver function test. Why? Because it assesses the function of the liver, okay, the hepatocyte itself. So how? So as we all know, the liver is responsible for producing albumin. So you have albumin, okay. Also the clotting factors. So they have the assessment of the prothrombin time, okay. Also ammonia, okay, because ammonia is a byproduct of the protein metabolism, in which the liver is also involved, okay. So here is a hepatocyte where we have illustrated the enzymes, different enzymes inside, and these enzymes become significant when the cell membrane, okay, the membrane is damaged. So for example, there is a damage. This is the microvilli, okay. This is the sinusoidal phase, okay, or sinusoidal part of the hepatocyte. This is the canalicular, okay. Sinusoidal, where the nutrients, okay, or whatever, the blood flow, okay, are passing in, okay. Or here we also have the biliary side, or the canalicular side, in which bile, okay, is excreted and down to the canaliculi, down to the bile ducts, down to the gallbladder, where it is stored, or it is also expressed or secreted down to the duodenum, okay. So you see different colors here. So the ones in violet, the one in violet is AST. We have two sources of AST. It's found in the cytosol, and it's also found in the mitochondria, okay, the one in blue. The one in red is ALT, okay, ALT. So alanine aminotransferase, okay. And normally you have more, okay, when the the damage of the hepatocyte is not that much, you have a higher level of ALT compared to AST, okay. But for example, if there is a damage, severe damage on the hepatocyte, wherein the mitochondria is already involved, leaking out additional AST, then you have more AST leaking out compared to the ALT, okay. So again, ordinary hepatocyte damage, you have increase in ALT, okay. Higher or more severe damage of the hepatocyte, okay, you have more AST compared to ALT, okay. The next enzymes that we see are, okay, ALP. The one in yellow is GGT, okay. The one in green is ALP, okay. So in the biliary side, okay, biliary side, you have or the canalicular side, you also have the ALP, the alkaline phosphatase, and GGT, the gamma glutamyl transferase, being produced on that side. How is this important? When you have an increase in ALP, okay, that means that there is a destruction or an obstruction in the biliary side. So that means we're talking about gallstones, number one. Number two, even the destruction of the hepatocyte itself at the canalicular side. So hepatocyte dysfunction that can also increase the ALP, but more on the biliary tract problem, okay. First, you have gallstone, you may have cholecystitis, okay. Second is, the last one is a GGT. Okay, GGT is increased in alcoholism. When there is when hepatocyte damage is secondary to alcoholism. Okay, so we will talk about these enzymes in particular later on. Okay, so I've given you a little glimpse about their function. Okay, so these are the normal values. You don't need to memorize. Okay, so when I give you a problem in the exam, I will always give you your reference values. So the first liver enzymes are the AST, aspartate aminotransferase, and ALT, alanine aminotransferase. Okay. Both of these are not entirely liver specific because these are also produced in other organs as well. Okay. For AST, it is found more commonly or produced more commonly by the heart, but it's also produced by the other organs. Okay. Next is for ALT, it's also produced by the kidney, but that's why they're not entirely liver specific. But if they are prominently increased, please consider the liver. Of course, correlate it with the history. So the higher the transaminase, more likely hepatic origin. Okay? Especially when the increase is more than 3 times the upper limit. So for example, more or less the normal levels of AST and ALT are 40 times 3, that is 120 to 150. Most likely that is secondary to a liver dysfunction. Okay, so here comparing both AST and ALT has a higher half-life. That means ALT persists in the blood longer than AST. And we have this certain ratio, a very useful or handy ratio that we call as the Deritis ratio. We have AST, that means AST over ALT. Okay? Remember what I told you before? When AST is greater than ALT, okay, here it is. AST greater than ALT, that means that this might be alcoholic hepatitis and additional and all forms of liver cirrhosis. Okay? When the injury is not that much, as we illustrated before, that might be a viral hepatitis. But if it will succumb, patient will succumb to cirrhosis, then AST will likely be increased more. Okay. So how do we relate this to the ratio? Again, if AST over ALT is less than 1, that means AST is lesser than ALT. Okay? That is normal. Okay? That is normal if it is less than 1. Okay? So, why? Because, again, AST is contained in the mitochondria. Okay? If more damage is done, secondary to alcohol or more severe injury, that will cause a leakage of more AST. So when AST is more, that means the ratio is AST over ALT greater than 1. Okay? If the AST-ALT elevation is just mild or less than 3 times the 3 times the higher upper limit, okay, that is very common among mild fatty liver disease. Okay, just have to repeat the test. Okay, or if the subsequent test is normal, then you just may you just have to dismiss it as probably an error, okay, or probably just a mild fatty liver. Okay, However, we can also see a fluctuating transaminase in hepatitis C. That's why we have to weigh out things. Persistently elevated transaminase that is less than 3 times, okay, needs further evaluation if it is persistent. So that means we have to consider other causes. Alkaline phosphatase, okay, bilirubin, okay, creatine kinase, hepatitis serology to check if there is a viral infection, serum protein electrophoresis, iron studies, and ceruloplasmin. Ceruloplasmin will evaluate the increase in copper, okay, copper metabolism, if there is a overload of copper, okay. For iron, that is hemochromatosis. Okay, so next is lactate dehydrogenase. For lactate dehydrogenase, we have mentioned this in the heart, okay, cardiac enzymes, cardiac panel, okay. It's found highest in amount in the heart, liver, red blood cells, and kidney. Next is the lungs, spleen, lymphocytes, and pancreas. And the least is from the liver. Okay. So in LDH, okay, so LD2 is produced more by in highest concentration normally in the kidney. Okay, LD1 is produced by more from the heart and the RBCs. Okay, so for example, if LD1 is greater than LD2, that means consider the following: myocardial infarction, hemolysis, and third is renal infarction. Okay, understandable if LD4 and LD5 are elevated. That means there may be a damage in the liver and the skeletal muscles. Okay, so we knew this already, that it must be in correlation with the cardiac troponin for the diagnosis of MI, and this enzyme is elevated in these cases as well: hemolysis, megaloblastic anemia, disorders of the liver, kidney, anywhere, because it has a lot of sources. Next enzyme is the alkaline phosphatase. But before we talk about the alkaline phosphatase, let's talk about phosphatases in general. We have alkaline, second is acidic. Okay, there are two types. Okay, let's go first with the acidic phosphatase. Okay, these are the sources are the prostate and the red blood cells and the bone. Okay, when the source is the red blood cell, it is called, the other term is the TRAP, tartrate resistant acid phosphatase. Okay, so you have a red cell, ACP. Okay, and this is distinguished from other ACP by susceptibility to inhibition of formaldehyde and resistance to tartrate. Okay, next is a prostate ACP. The other term is non-TRAP. Okay, and it is a serum marker for prostate cancer. Okay, probably I think bone also is also considered as a non-TRAP. Okay, if it produces acid phosphatase. But mind you, alkaline phosphatase is also produced by the bone. Next, alkaline phosphatase is present in most tissues. Again, concentrated in the bone, the liver, biliary epithelium, the gallbladder, okay, intestine, and the placenta. Okay, and these are the different types. Okay, and how do we distinguish? Number one, respectively, through heating, we distinguish the bone ALP. Through urea incubation, we distinguish the biliary ALP. Through addition of this amino acid phenylalanine, okay, we distinguish the placental ALP. Okay, so biliary, bone, placental, and intestinal. What did we miss? Okay, so placental, okay, placental, intestinal ALP, okay. It's also identified by both, no? We have the urea incubation by heat, okay, but more on the inhibition by the phenylalanine, okay. So another term for placental ALP is the Regan isoenzyme, okay, so please take note. And in general, okay, ALP, okay, we mentioned that ALP is produced by the biliary epithelium and the liver, okay, from the bone, okay. What else? The placenta, okay. What else? The intestine, okay. But when ALP is increased, we need further confirmatory tests, okay. So when ALP is increased, there are still many differential diagnoses. Number one may be obstruction from the gallbladder, from a stone. That's very common. Next is a cholecystitis, okay, inflammation, okay, or whatever that deals with the biliary epithelium, such as biliary cirrhosis. You may have increased ALP there, okay. But we need adjunctive tests such as the GGT and the nucleotidase, okay. If these are normal, okay, the excess ALP is most likely bone origin, okay. If the GGT and the nucleotidase are abnormal, okay, the excess ALP is most likely what? Liver in origin, okay, most especially if it's secondary to an alcohol damage on the hepatocyte, okay, because GGT is an indicator for alcoholism, okay. Can also be it can also be secondary to of course, consider the gallstone obstruction, okay. But if GGT is increased prominently, consider alcoholism, okay. So the significant elevation of ALP in non-pathologic conditions are very common, okay. For example, we have in growth, normal growth, secondary to the increase in the growth of the bones, okay. Next is pregnancy. Of course, the fetus, we have the sources there. We have the placenta, okay, placental ALP, and of course the ALP coming from the bone of the growing fetus, okay. Next is the another non-pathologic condition is also coming from the intestinal ALP, okay, secondary to meal ingestion, okay, or intake of medications such as oral contraceptive pills. Minor ALP elevation is also a problem, okay, common problem, and it's seen in liver disease, unrecognized pregnancy, bone disease, congestive heart failure, okay, hyperthyroidism, and drug exposure, okay. So just take note, What are the sources of this ALP? You may have biliary epithelium, that means the gallbladder. You also have the liver, okay? Because I showed to you the illustration on the canalicular side of the hepatocyte. You also have a source of ALP there, okay? And also the bone, okay? CHF may be an indirect cause, because if there is CHF, there is congestion in the liver, okay? It's a sensitive marker of hepatic metastasis, okay? Especially when the metastasis comes from the gallbladder or the biliary epithelium, bile duct, okay? We mentioned this in the lecture, that when we have an increase in my antimitochondrial assay, especially in middle-aged women, then consider primary biliary cirrhosis, okay? And you also have increased in ALP. Okay, significant ALP elevation is seen in the following: extrahepatic biliary obstruction, primary biliary cirrhosis, severe drug-induced hepatocellular cholestasis, and Paget's disease of the bone. Okay, decrease in the following decrease in the ALP is found in the following diseases, okay, or following conditions. You have hypophosphatasia, malnutrition, Wilson disease, theophylline therapy, and estrogen therapy. Okay, so next enzyme is the gamma glutamyl transferase. Okay, it is to confirm that the elevated ALP is from the biliary tree. It's highly sensitive indicator of biliary injury. Okay, so the higher GGT, that will tell us that it may be secondary to first is an obstruction, okay? Second is when there is a presence of the toxin. These are the following toxins, okay? Most especially alcohol, okay? So again, the sources of GGT is the biliary epithelium, as well as the microsomes or the smooth endoplasmic reticulum of the hepatocytes, okay? That's why we consider obstruction, okay? Second is alcoholism, as well as the presence of the other toxins as well, okay? It is a marker of alcohol consumption. However, it's not only exclusive to the liver, because it is produced by the kidneys and the pancreas. And here is a summary of the enzyme, as well as the major diagnostic use of it. Okay. Next is nucleotidase. Okay, again, it is the main source is the biliary epithelium. Okay, and it's elevated in cholestatic conditions mentioned about gallstones, cholecystitis, cirrhosis. Okay, it's a confirmatory, okay, for an increased ALP, but it is less commonly utilized compared to GGT. Ammonia, okay, is a byproduct of protein metabolism. Okay, normally it is removed by the liver, okay, and detoxified into urea, okay, which is excreted in the urine. However, in liver failure, okay, secondary to the following conditions: dysfunction, collateral circulation, and excess protein in the gut, you have ammonia lingering in the blood. Okay, and it crosses the blood-brain barrier and cause neurotoxicity. Okay, so just you have lactulose. Okay, the lactulose as a treatment to ammonia encephalopathy, or even as early as cirrhosis. Okay, it converts ammonia to ammonium. This is a non-toxic form. Rifaximin, okay, kills the bacteria that converts protein to ammonia. Okay. The causes of hyperammonemia are the following. You have it, of course, in liver failure, maybe an error. Okay, it may be an inborn error of metabolism, urea cycle enzyme deficiencies. And how do we measure? We have to place it in a cold storage to prevent hemolysis. Okay, so the test has to be done immediately, and smoking has to be avoided. Okay, and these are the causes of hyperammonemia: liver failure, okay, and an inborn error of metabolism, okay, total parenteral nutrition, okay, and take note, most especially cigarette smoking. Okay, and before we discuss bilirubin, let me talk about bile. Okay, so the bile is composed of bile salts, okay, phospholipid, cholesterol, and bilirubin. Okay, that's why when there is an obstruction, okay, you also have a problem in the cholesterol. You have obstruction of bile, you may have an increased cholesterol because fats are not metabolized if there is an absence of or lesser production of bile secondary to obstruction. Okay. Again, next is the bilirubin, and this is the bilirubin metabolism. Okay, bilirubin is a what they call this, is a substance that is derived from heme. Okay, it is a oxidized reduced form of heme. Heme is obtained from hemoglobin, which is a pigment of the red blood cells. Okay, out of some processes, the heme and globin, okay, of course, the red blood cells become degraded. Okay, the heme and it gets separated from the globin. Globin gets recycled in the liver. The heme is being processed. Okay, and I'll just use this figure to discuss the bilirubin metabolism. Okay, so I think this is the more appropriate figure. Okay, so the red blood cells, okay, are the main source of the heme. Okay, and breakdown of the heme to bilirubin is broken down by the macrophages in the liver, in the spleen, and tissue macrophages. Okay, so let's concentrate on the bilirubin. It gets transported to the liver, okay, being complex to albumin. Okay, so the first form of bilirubin before entering the liver, okay, is the unconjugated bilirubin. So that's why when there is hemolysis, bilirubin leaking out, that is unconjugated or indirect bilirubin. Next, it enters the liver and it is being conjugated with glucuronic acid by the enzyme, what enzyme? Glucuronidase or glucuronyl transferase. Okay, why do we need to conjugate? Because it needs to be soluble because it needs to be dissolved in the bile in order for it to be excreted or stored. Okay, so conjugated bilirubin is actively secreted into the bile and then in the intestine. Okay, in the intestine, glucuronic acid is removed. So it is conjugated only to be removed when it is already in the intestine. The resulting bilirubin is converted to urobilinogen. So this is again the so the better term is deconjugated bilirubin. Okay, so it is further metabolized. Okay, so deconjugated bilirubin can participate in the enterohepatic cycle. Okay, it's being recycled, or majority is being dumped out in the feces, okay, in the form of stercobilin that will give a pigment in the stool. Okay, so when there is no pigment, that is what we call a colic stool. Okay, or it is the other term is a silver stool of Thomas. Okay. Another pathway is the urobilinogen becomes converted to urobilin and gives the urine its characteristic color. Okay, so that is the bilirubin metabolism. This is a very nice figure because it illustrates the bilirubin metabolism in the cellular level. Okay, so just take note, whatever is in the sinusoid space, okay, this is the microvilli, the sinusoid space, this is the unconjugated bilirubin. Okay, the one in orange is the unconjugated bilirubin. When there is hemolysis, you have high levels of that. Okay, next is it's being conjugated here in the hepatocyte. Okay, you have the enzyme here, letter C, or glucuronil transferase. Okay, so that is here. So hemolysis, unconjugated hyperbilirubinemia. Okay, but unconjugated hyperbilirubinemia or unconjugated hyperbilirubinemia can also be caused by not only hemolysis but a problem in the glucuronidation here. Okay, and if it's secondary to an inherited disorder, then you have two choices: either the Gilbert Syndrome or the Crigler-Najjar syndrome. So the more severe is the Crigler-Najjar. Okay. So if there is a problem with the also a milder form of inherited unconjugated hyperbilirubinemia is also secondary to a deficiency of this transporter protein in the sinusoidal side. Okay, mild. Okay, that is Gilbert syndrome. Okay, next, you may have a conjugated hyperbilirubinemia. Okay, if number one, if there is a an obstruction in the biliary tract. That's number 1. Okay. Number 2, if there is a problem in the or deficiency in the secretory protein. Okay. You might be confused. We have two types of protein involved in this picture: the transporter protein and the secretory protein. In the future slides, I'm using the term protein transporter. Okay. So in order for you not to be confused, the protein transporter that I'm talking about is the secretory protein. Okay. So if there is a deficiency in the secretory protein or the protein transporter, okay, that will also lead to an increase in the unconjugated bilirubin. Okay. Next, if the problem is inherited, an inherited bilirubin disorder, then that is, they have two choices: either the Dubin-Johnson syndrome and the Rotor syndrome. Okay, so Dubin-Johnson or the Rotor syndrome. What's the problem there? It's also in the deficiency of the secretory protein or the protein transporter. Okay, leading to a retention of conjugated bilirubin. Okay, so you may be confused, but we'll talk about it one by one. Okay, so bilirubinuria always indicates conjugated hyperbilirubinemia because bilirubin, okay, is never normally found in the urine. What we can see in the urine is urobilin. Okay, the bilirubin that we are talking about is the conjugated form. Okay, so if you see bilirubin in the urine, next step is to check if there is a conjugated hyperbilirubinemia. Check for the direct bilirubin or the conjugated bilirubin. Prolonged conjugated hyperbilirubinemia is secondary to linking of bilirubin to albumin, okay, to form beta albumin. And because of that, beta albumin is a complex between the bilirubin and albumin. Okay, it is unexcretable. Okay, so that is a one condition of conjugated hyperbilirubinemia, but that is less common compared to what we have mentioned before. Okay, so bilirubin measurement is through the following: through the diazocolorimetric method, okay, wherein you use a you base the measurement of the bilirubin through the addition of this diazo, okay, which will produce a colored dye. Okay, so conjugated bilirubin is measured without the accelerator. Okay, total bilirubin is measured when you have more accelerators added. Okay, and the difference is what is the unconjugated bilirubin. It can also be measured through direct spectrophotometry. It is the difference between the absorbance, bilirubin absorbance at 455 minus the absorbance at 575. So the result is the total bilirubin. Urine foam, when you see bubbles or foam, okay, yellow foam, that is bilirubinuria. And of course, the modern or the less modern or the modern, okay, relatively modern, it's a dipstick method. So here is an illustration that pictures out the different types of jaundice. Okay, you have prehepatic, so this is increased, okay, increased indirect or unconjugated bilirubin. Okay, hepatic, which you have two, increase in indirect bilirubin. For example, if there is an absence of the enzyme, okay, or increase in the direct bilirubin when there is a problem with protein transport. Okay, post-hepatic, when there is an obstruction, okay, obstructive jaundice secondary to stone or tumor, okay, or sepsis. Okay, so here are the examples or conditions leading to unconjugated hyperbilirubinemia. Hemolysis, decrease in uptake or conjugation. Okay, of course, when there is a failure in conjugation secondary to a deficient enzyme, then that leads to increase in unconjugated bilirubin. Okay, in inherited disorders or hereditary disorders of bilirubin metabolism leading to unconjugated hyperbilirubinemia, you have two conditions. You have Gilbert Syndrome, which is flashed in front of you, and Crigler-Najjar syndrome. Gilbert syndrome is secondary to a deficient glucuronidase. Deficient. Okay? Because in Crigler-Najjar, it is secondary to complete absence of glucuronidase or glucuronyl transferase. Of course, we have varieties, no? Type 1 and type 2. But in general, this is a complete absence of glucuronyl transferase. So, showing you again. So, Crigler-Najjar, you see it in neonates and it is fatal. Okay? Gilbert syndrome, since it's not fatal, it will exist until the baby is has already grown. Okay. Next, for conjugated hyperbilirubinemia, it's secondary to an excretory defect of the conjugated bilirubin. Okay. So excretory defect, it may be secondary to a obstruction. Okay, take note, obstruction, or second is a problem in the transport, protein transport. Okay, so it may be secondary to a problem, hepatocellular, or the cholestatic disorder. And if the problem is hereditary disorder of bilirubin metabolism leading to conjugated hyperbilirubinemia, we have two conditions. If you have an absence of the transport protein, or previously we mentioned this is the secretory protein, okay, secretory protein, and this is Dubin-Johnson syndrome, when there is complete absence. When there is a deficient, that is a rotor syndrome. So the complete absence of the transport protein, okay, I'm pertaining to the secretory protein in the illustration, okay, in the canalicular side, okay, that will lead to a black liver. And here is a summary of the different conditions leading to hyperbilirubinemia. To add, okay, which later we also have this one in the next part of our lecture, physiologic neonatal jaundice. It is secondary to an immature glucuronidase transferase or immature glucuronidase, okay, leading to a unconjugated hyperbilirubinemia also. Okay, how do we treat it? Just phototherapy. Okay. Again, the hereditary disorders. And these are the differential diagnosis of hyperbilirubinemia. You just have to go through. Okay. And for conjugated hyperbilirubinemia, okay, so how do we tell if it's a hepatocellular cause or cholestatic cause? Number one, alkaline phosphatase. If it's highly increased, and that is cholestatic jaundice. Okay. If transaminase is higher, and that is hepatocellular. Okay. If serum cholesterol is increased, and that is cholestatic, because we need the bile. Okay, if there is obstruction, there is a problem in the production of bile. Okay, so therefore cholesterol is not metabolized. Pruritus, secondary to overflow of bilirubin. Okay, coming from the biliary side. Okay. Here, if albumin is decreased, we know that albumin is produced by the liver. Okay, it's hepatocellular. Bilirubin is highly increased, most likely that is cholestatic. Both conditions increased produce, okay, increased urine bilirubin, and the prothrombin time is prolonged. Okay, both. But the causes are different. Why? For hepatocellular problem, if the problem is in the liver, it is secondary to a problem in the clotting factors. Okay? That's why when you add vitamin K, there's no reaction. The prothrombin time is still prolonged. When you add vitamin K in a cholestatic condition, okay, it will have a response. You have decrease in prothrombin time. Okay? Because the problem here is when you have an obstruction, you have decreased production of bile. Okay, and there is then vitamin K is not absorbed because vitamin K is absorbed in the presence of bile. Okay. So prothrombin time is an indicator of the clotting factors, presence of clotting factors. Okay. Then this is very important again. To distinguish if the prolonged PT is due to cholestasis, then just have to add vitamin K because prothrombin time will shorten upon administration within 24 hours. Okay, if the problem is secondary to cholestasis. Again, both prothrombin time are prolonged in both cases. However, if you add vitamin K vitamin K If there is a decrease in prothrombin time, then that must be secondary to an obstruction in the biliary tract and other biliary tract conditions also. Okay, so next, gamma globulin. So gamma globulin is an antibody, that is IgG. Okay, when elevated, okay, it is indicative of a condition called autoimmune hepatitis. When IgM is elevated, it is indicative of primary biliary cirrhosis. So we have this albumin globulin ratio. Okay, when you have a decrease in albumin, and that is indicative of liver disease. So decreased albumin leading to a decreased AG ratio. Again, albumin is produced by the liver, okay, but it lacks specificity, okay, due to the many causes of decreased albumin. Of course, no, decreased albumin can also be caused by malnutrition. Okay, lack sensitivity because albumin can still be normal in cirrhotic patients. Some serum protein markers. Additional, we have the alpha-fetoprotein, which is a marker for hepatocellular carcinoma and for neural tube defects secondary to aflatoxin. Alpha antitrypsin, this is a condition, if it's increased in emphysema. Okay, when you have also, it can also lead to liver cirrhosis, because when you have increase in antitrypsin, there's retention of antitrypsin in the liver, then it destroys the liver. Ceruloplasmin, it is decreased in a condition called Wilson's disease, which is a increase in the copper levels in the blood. Okay, leading to Kaiser-Fraser rings. Okay. We now go to neonatal jaundice. So this is jaundice in the newborn. Okay, so a 3-day-old neonate born after 32-week gestation develops yellow skin. PE of the infant is unremarkable. What is the most likely to be increased in this neonate serum? Okay, so 3-day-old. Okay, most likely the cause of this yellowing of the skin is unconjugated bilirubin. So most cases of neonatal jaundice are benign, thus called physiologic jaundice. This results from the immature hepatic enzyme, particularly the enzyme that we're referring to is the glucuronidase, okay, resulting to the build-up of unconjugated bilirubin. But don't worry, because this is just mild and transient. The characteristics of physiologic jaundice are flashed there. It is noted between day 2 to 3 of neonatal life. So it's not noted right away as soon as the baby is born. Okay, it's noted a bit on the 2nd day to the 3rd day or within the week. Okay, and it rarely rises at a rate of more than 5 milligram per DL per day. It peaks by day 4 to 5 and rarely exceeds 20, because if it exceeds 20, it's not anymore physiologic. It is already a condition known as Kernicterus. Okay? Most common causes of severe neonatal hyperbilirubinemia. Number 1, it's hemolytic disease of the fetus and newborn. Okay? So there is a incompatibility of the blood, no, between the mother and the fetus. Next is sepsis. So there's infection. Okay. The poorly developed blood-brain barrier permits unconjugated bilirubin to cause damage to the CNS. So that's why this unconjugated bilirubin is very harmful. When do you worry? Okay, these are the signs when you have to worry. Okay, the jaundice basically is severe and prolonged. Okay, prolonged in such a way that you see jaundice right there and then. First 24 hours of life, rising bilirubin beyond 1 week of age, persistence of jaundice beyond 10 days, total bilirubin greater than 12, single day increase of greater than 5, and conjugated direct bilirubin more than 2. Okay? In a healthy term infant, if you find these levels of bilirubin that is above 10, or basically above 10, okay, you have to have the baby undergo phototherapy, okay, because this phototherapy converts the unconjugated bilirubin into a soluble form. Okay, the treatment for Kernicterus is what we call as direct vein exchange transfusion, okay, wherein the a fresh blood of course of a compatible type, okay, is transfused to the baby. Okay, and there is a outflow of the blood containing the unconjugated bilirubin. What are the differential diagnoses of neonatal jaundice? Okay, it depends if it's conjugated or unconjugated bilirubin, okay, which is elevated. Okay, so these are the differential diagnoses. Okay, take note, you have sepsis, infection, okay, erythroblastosis fetalis, okay, that's still under hemolytic disease of the newborn, okay, of the fetus, that's of the fetus, because it's fetalis. Okay, so this is how an infant with jaundice looks like. Okay, even breastfeeding or breast milk can cause jaundice, but it's just transient. Okay, transcutaneous bilirubin, okay, is a method of obtaining bilirubin without the use of venipuncture, because if we do venipuncture routinely, it can do serious trauma on the infant, on the neonate. Okay, so these are the causes of neonatal hyperbilirubinemia. Okay, so please, if you can't understand why, okay, you can just by all means memorize. Okay, so take note: physiologic jaundice, breast milk jaundice, hemolysis, we mentioned that, okay, infection, obstruction, okay, and not to forget our Dubin-Johnson and Rotter, as well as the Gilbert and Krigler-Nehar. Okay, as I've said before, this is under the topic bilirubin. Okay, so we're done with neonatal jaundice. Now let's go to viral hepatitis. So we'll focus on the not really the epidemiology of the virus, but the markers. Okay, so particularly we're dealing with the viral markers. So the case is a 27-year-old man with a history of IV drug abuse is known to have been infected with hepatitis B. Okay, he's seen in the emergency room with having nausea, vomiting, passage of dark-colored urine. Okay, for the past week. Okay, so there is bilirubin nuria. Okay, and physical examination shows scleral icterus and mild jaundice. Neurologic examination shows a confused, somnolent man oriented only to person. He exhibits asterixis, and the labs are total protein 5, okay, albumin 2.7. Those are low. AST 2342, that's high. ALT, that's high, 2150. Alkaline phosphatase, that's still high. Okay. Total bilirubin, that's high. Direct bilirubin, that's still high, 4.5. Okay, the question is, superinfection with what hepatitis virus has most likely occurred in this man? So the case is a case of a hepatitis B. So when we hear the question superinfection, there's only one answer. It's hepatitis D. Okay? So in general, acute hepatic injury presents with jaundice, elevated transaminases, and we know the pathophysiology and the constitutional symptoms such as fever, okay, and may be caused by the following. Okay, the following help to point the specific etiology. Of course, the proper history, and we need the help of hepatitis markers, ANA. Okay, if it deals with ANA is anti-nucleic acid, okay, assay, so that deals with autoimmune hepatitis. Ceruloplasmin, that deals with copper, so that's Wilson's disease, drug history, and the changes in the liver function test. Acute viral hepatitis due to A or B often leads to complete recovery. Okay. However, we've said this in the lecture in GenPath. It's in hepatitis C. Hepatitis C goes to chronic form. Okay, chronic phase. Majority of hepatitis C. So be careful. Okay, and the reliable markers for viral infection, namely Hep A, we have IgM, okay, IgM. Hep B, it's the number one, first and foremost, it's the HBs, okay. And actually there are a lot, okay, but the most prominent is the HBs, okay. For the HCV, for hepatitis C, okay, we cannot rely on the antibody. More particularly, we can rely on the RNA, and we will discuss it later. Okay, let's do a recap, okay, in about transaminases such as the AST and ALT. Okay, if the cause is an ischemia, okay, ischemia, okay, that shows an elevation of more than 100 times of the upper limit. Okay. If the AST is greater than 3,000, most likely that is a toxin. So in other words, even ischemia, okay, can really cause an elevation of transaminases. Ischemia secondary to a blockage of a thrombus or a parasite. Okay. Toxin. Okay, more than the viral hepatitis. Okay, so here we mentioned this one. So in the slides, many slides before, we mentioned that if it's alcoholic hepatitis, then that is the AST over ALT is greater than 1. Okay, but according to this slide, to this source, I use a different source for this. It's more than 2. But let's make it general. For alcoholic hepatitis, it's greater than 1. Okay? Maybe for toxic and ischemic, it's maybe greater than 2. The Diritis ratio is greater than 2. Okay? For viral hepatitis, okay, and a mild injury, the diuresis ratio is less than 1. Okay, unlike the prothrombin time and bilirubin, the degree of transaminase elevation poorly reflects on the hepatic injury. Of course, because this transaminase elevation or transaminase only reflects on the hepatocyte integrity. The prothrombin time and the bilirubin, okay, reflects on the hepatocyte function. So, bilirubin manifests as jaundice in 70% of hepatitis A and alcoholic hepatitis, and 30% only in hepatitis B and hepatitis C. Okay? So, these are your main considerations. A bilirubin of more than 15 indicates a severe liver injury. Okay. Prothrombin time greater than 4 seconds, prolonged greater than 4 seconds, indicates severe liver injury. Okay. Again, prothrombin time indicates what is it? Is an index of the function of the clotting factors. Again, I showed this before in GenPath, and what we are going to focus are the antibodies. Okay, antibodies that will rise and fall through the course of time. Okay, I added hepatitis G because it's one of the actually it's rare. Okay, but it merits mention. Okay. So again, hepatitis A, it's foodborne, fecal-oral route, okay? And take note that chronicity does not occur. Acute infection, okay, is shown by the IgM. Okay, so here is the figure. So we have the antigen here, but before the antigen drops, we already have antibody. Antibody for the antibody for the virus, that is for the acute, that's IgM. Okay, this one, it's not shown, the IgG is not shown, but we can assume that the total anti-HA, okay, already includes the IgG. Let's go to hepatitis B. So, just a review, we have many particles coating around hepatitis B virus. Okay, so we have HBS, which is outside. Next is HBE, envelope antigen, and the one inside is the core, just outside the DNA. Okay, the only DNA virus is the hepatitis B. This particle, the whole particle, is what we call as the Dane particle. Okay. For your convenience of studying this, we assign a meaning for each antigen and antibody. So when you see a positive HBS, that means that the patient is in active disease. Okay, or the patient has been infected. Okay, but if you see a positive HBE, that means that the patient is active viral replication or in active infection. So take note, active disease, HBS, active infection, HBE. Okay, acute infection, HBE. Okay, the antibody towards the core, so IgM, reflects acute infection. Okay, the total, if it's total, it reflects both acute and the past, acute and the chronic. Okay, but it's the IgG that reflects on the what they call this, the chronic. Okay, but usually what you can see in the graph is the total. Okay, antibody towards the HBE, that means that the patient is not anymore infectious. Okay, and antibody to the HBS, that means that the patient is already immune to the infection. Okay, so resistance to infection. If you might wonder, there is no HBC or the core antigen, it's because you cannot get the level, the core antigen from the blood. It stays in the liver. Okay, so the serological markers begin to emerge 2 to 10 weeks after exposure. So if you take note, if you notice, the incubation period of hepatitis B virus takes a longer time. Okay, incubation period means the time before the symptoms appear. Okay, take note, hepatitis B, you have a longer incubation period compared to hepatitis A, the fecal oral. Okay, but for the blood transmitted, from the needles, infected needles, vertical transmission, and not the vertical transmission, it needs a more time to incubate. So this is the chronological order of appearance. Okay, so you can just read through them. Okay, and this is a very important slide. Okay, so we have the incubation period, then you have the rise of the HBS. Okay, by the way, this is the time course of appearance of the antigens and the antibodies. Okay, when we say it doesn't mean that for example, at this part, the patient is not having does not produce antibodies. Okay, it just means that at this part, when antigens are more prominent, the antibodies are lesser in amount, because of course when you have antigen interacting or interacting or forming a complex with an antibody, then there's a cancellation. So I think it's the law of cancellation. Okay, so don't get it wrong. At this point in time, there are already antibodies. You already have antibodies. It's such that it's just unfortunate because the level of the antigen goes higher compared to the antibodies. Okay, but at this time, at the later part, you have the antibodies seen in the graph. It means that the antigen is way lower. Okay, and compared to the antibody. So there's a cancellation between the antigen and the antibody. So at the left side, you see the antigen. At the right side, you see antibody. Okay, this is still in the acute. Okay, how do we detect that how do we determine that this is an acute infection? Take note, the HBS goes down here. So therefore, the infection does not persist for a long time. Okay, take note also that you have a period where you don't see a positive HBS and the antibody to that. Okay, this is what we know this is what we term as the window period. Okay, and this is very crucial. That's why this is very crucial, because in the window period, if you don't know about the history of the patient, you might, if you're just getting the hepatitis B and surface antigen, you might mistake it as a negative hepatitis infection, whereas while in reality we are still in the window period. Okay, so what you might ask, what viral marker do we get if we are in the window period? You cannot use the HBS because it leads to nothing. You cannot rely on the antibody because we don't see antibody yet. Okay, we don't detect antibody yet. What is reliable is the antibody to the core here, IgM, anti-HBC IgM. Okay, so let's trace, no? So HBS starts to appear, then next goes high, then we see HBE. So patient has been infected and patient is infectious here, so careful. Okay, and by this time you have the IgM anti-HBC. Okay, IgM begins to rise, the antibody. Okay, and you also see the rise also of the anti-HBC total. So this is a protection. Okay, protection that will that this is an antibody that will protect the patient also for a long time. Okay, but it's really the anti-HBS that will make the patient immune to hepatitis B virus for a long time. Okay, so when the patient already has the antibody to the HBE, that means that the patient is not anymore infectious at this time. Okay, and much later you have the antibody to the HBS. So if you notice, there is no overlap between the antibody to the HBS and the HBS antigen. Okay, because they are separated by the window period. Okay, so if you're given a result of, for example, HBS positive and the rest are negative, so that means that the patient is in active disease, has been infected. I'm not saying infectious, has been infected. Okay, so the patient is in incubation period still. Okay, or what we say as what? Active disease or acute disease. Now, if the patient is positive for HBS, then patient has a positive total. Okay, that means that the patient had infection and we just have to check if it's acute or chronic. We get IgM, it's positive with IgM, and that means it's an acute infection. So acute infection, at the same time patient is infectious, so therefore we are in acute Hep B infection. So again, we have to draw the line between being infectious, okay, and having the infection. Okay, do you know what I mean? Okay, the first one, the patient is not infectious. Patient has been infected but not infectious. The second one, the patient is infectious. Third, here, HBS negative, okay, but you have an acute, okay, and the patient is not anymore infectious. Here, not anymore infectious, and the patient is already immune. Okay, that means that this is a resolved case. Recent. Next, what if negative HBS, then positive IgM, okay, and the rest are negative. So it is acute. Okay, so that means the The rest are negative. HBS and anti-HBS is negative. Only IgM. Okay, this is what we call, I mentioned before, as the window period. Next, HBS positive. Then negative for IgM. So this is chronic. Okay, but positive for HBE. So the patient is infectious. That means this is a case of a chronic infection. Okay, you know the pattern. Just give meaning to each viral marker. Next, HBS positive. Then this is a chronic because negative for IgM. But patient is positive, already positive for anti-HBE. So therefore, patient is not anymore infectious. Okay, so this is a chronic carrier. So chronic carrier state. Okay, and we will see it later in the chronic HBV. Okay, so we see different phases also. In the carrier is not infectious. Okay, but still has the Hep B surface antigen, the virus itself, but not infectious. How about this one? Okay, chronic. Okay, then with anti-HBS. Okay, with anti-HBE. So not anymore infectious. Patient is already immune. Resolve Hep B infection. How about this one? You just have the antibody. No HBS, no HBE. This is a case of HBV immunity after vaccination. Okay, because you're given, you have this antibody towards the HBS, but you haven't been infected. Okay, see? Okay, next, if you have nothing, that's neither infection nor immunization. You get it? Get it, class? So just review it. Okay, so this is the summary of the meaning for each antibody and antigen. You just have to go through these, okay, later. So the window period, again, is the brief interval between the disappearance of the HBS antigen and the antibody. Okay? And there's a small group of patients presenting with only a positive antibody to the core. First thing that will come into our mind is, we mentioned it before, it's a window period. However, there are also instances wherein you have a chronic Hep B infection, wherein the levels of HBS have become undetectable. Okay, so we have to check for the HBV. Okay, so for example, this one has become negative from being positive, then we have to check the HBV. Okay, next, if you have a anti-HBS that has become undetectable, such as in HIV, because you have a immunocompromised patient. Okay, and non-specific false positives. So let's go to chronic hepatitis B. The chronic hepatitis B is defined as hepatitis, according to timeline, more than 6 months. Okay, this is, we're not saying the patient is infectious or not infectious. It can be both. Okay, you may have you may have Hep B, hepatitis B and E positive or negative, depending on the phase. Okay, so that's the first criteria, timeline more than 6 months. Then the DNA has risen to 20K, okay, IU per ml, or 100,000 copies per ml. Okay, if you have values 2000, in between 2000 to 20k, less than 20k, that's seen as negative for HBE. Okay, so these are the initial testing in patients diagnosed with chronic Hep B infection. So namely the CBC liver profile, INR, to assess the liver function. Okay, HBV replication, you see, if the higher the DNA, the more infectious. Okay, positive HBE, infectious, to rule out viral co-infections, because the route of infection for B and Hep C are very much the same, as well as HIV. Okay, the test for screening and surveillance, okay, for hepatocellular carcinoma is also important. That's, we need AFP and ultrasound. Okay, so how do we detect if it's an acute infection based on the graph? Check for the HBS. HBS goes down. This is acute infection. Okay, this one, HBS persists for a long time. That is chronic infection. So what do we do for a patient that we suspect for as having chronic hepatitis B? So we just have to first check on the history. Okay, if the patient has results persistent of Hep B surface antigen positive for 6 months, then that is chronic hepatitis B. Next is get these labs. Okay, and we know the meaning of each, right? And by this time, we will appreciate the significance of ALT and HBV DNA. So for chronic hepatitis B, it's better yet to monitor the HBV DNA. Okay, the rise and fall of the DNA. Okay, but if it's negative, then you have to check for the antibody. If the antibody is positive, then the patient is immune to the virus. If the patient is negative for antibody, then we have to vaccinate. Okay, so vaccination with Hep B, we are giving an inactivated or an attenuated virus, introducing an attenuated virus so that we can build antibodies against the virus. Okay, so there are 4 phases of chronic hepatitis B, namely the immune tolerance, okay, immune clearance, inactive carrier, and the reactivation. So how do we say that it's tolerance? So tolerance means that the DNA is still rising. Okay, how do we say that it's immune clearance? You have here the DNA, although at the earlier part you have greater than 20K, at the later part you have a lowering of DNA. So therefore there is a clearance. Okay, the DNA of the hepatitis B virus, there is clearing out. Okay, next, the carrier. So why do we say that it's carrier? At this point in time, you see already the patient is not infectious. Okay, although still positive for HBS. And you have a lesser viral load. However, don't be complacent. There will come a time where the patient will have an increase of HBV DNA. Okay, so here, so candidate for therapy, it's during the immune clearance and the reactivation phase. because of the inflammation. Okay? You notice you have the ALT soaring high at these phases. Okay. If you notice also here, at the reactivation phase, you have a negative HBE. But do we have to be complacent, or does it give us an assurance that the patient is not anymore infectious? No. Okay? No. Why? Because the DNA is rising. So this phase is the exception. Okay? You may have a positive DNA, high increasing DNA, but not anymore with the HBE. So be careful. Okay? So that's the simplified graph, okay, showing us the enzymes. The carrier is a HBs positive without clinical hepatitis, without signs and symptoms, and it's very common among vertically inherited hepatitis B. And next are the patients that have gotten this infection horizontally, okay, associated with polyarteritis nodosa, because when the patient, I think it's 30% of patients with polyarteritis nodosa have hepatitis B. Okay, superinfection or co-infection with Hep D occurs only in hepatocytes infected with Hep B. Okay, so Hep B and D go hand in hand. So if you have a case of a positive HBs, these are the minimal laboratories to request. Why? HBE will tell us that the patient is infectious. Anti-HBE will tell us if the patient is not anymore infectious. ALT, okay, levels, and the ultrasound to check if the patient has already cirrhosis, or at least the severity of the hepatitis. And the genome, so very easy. S, surface antigen, S gene, C gene, core antigen, P gene, DNA polymerase. Okay, and can undergo mutation that can lead to abrupt progression of chronic hepatitis B. Okay, so that's why this is a there are patients that have been given a antiviral, okay, but for no reason in the near future the antiviral will not anymore be effective, or will not anymore decrease the level of the HBV DNA. Okay, this is the reason why, because of mutation. And next is again mutation. Okay, so this is lamivudine resulting in decreased binding of lamivudine. Okay, lamivudine is one very common antiviral for hepatitis B. Molecular assays are used to determine if you're unsure of your viral marker serology. Okay, to distinguish between replicative and non-replicative. So molecular assay, that means that we are measuring the DNA, okay, and for monitoring therapy. So if you can afford, by all means order the DNA itself, HBV DNA. Okay, so when it's equivocal, okay, check for the DNA, and it's detected 3 weeks ahead of the HBs. Okay, distinguishing replicative versus non-replicative. This HBE is not detectable in reactivation disease. Well, we mentioned before, right? And the HBV DNA is more preferred. Okay, only in the reactivation phase where you have an increasing DNA, but the HBE is not present. So we don't know why, but that's the way it is. And for monitoring therapy, so we use the DNA. Levels of DNA will tell us positive when there is lowering of the DNA, that is a positive virologic response. Okay, so if again, if the result in the other serological markers are questionable, then check for the DNA. Whereas the other monitoring parameters, okay, such as a liver biopsy, will tell us if there is improvement, and that is a positive histologic response. When there is an improvement or lowering of ALT, that is a biochemical, definitive biological response. Let's go to hepatitis C virus. Most chronic cases, majority is in hepatitis C. Okay? And it's transfusion or needle, infected needle related. So this is more on the blood. Okay? Hep B is more on the sexual means. Okay? And in the diagnosis of hepatitis C infection, you cannot really rely this one, okay, rely really on the antibody to the, although yes, if it's positive, then it might indicate infection, but by all means get the RNA, okay, because it is the best predictor of treatment response. Okay, but if you're going to assess the severity of the destruction, such as in cirrhosis, okay, we don't use the RNA. Okay, we cannot, what do you call this, you see, in assessing if the patient needs to be treated, okay, we don't use the RNA. Okay, we use the liver biopsy. Okay, only for hepatitis C virus, hepatitis C disease, to assess if the patient needs therapy, okay, we need first liver biopsy. But after the biopsy and the patient has been started with medication, if you want to check if the patient is responding to treatment, then check for the RNA. Okay, that's how we use it. The RIBA, recombinant immunoblood assay, is a confirmatory test for the presence of the antibodies. Okay, so I'll show you. So here, if you have a positive HCV, that means that the patient is infected, however, without the antibodies yet. Okay, of course, no antibodies, so therefore, it's negative. Okay, next, if the patient is positive HCV, then positive for antibody, so that means that the patient is in active infection, but there's no clearance yet because you still have the RNA. And the RIBA, positive RIBA, will tell us that there are really antibodies. Next, here, if you have a negative already here, and a positive for antibody and positive, so that means this is a true infection. Okay, that means that there is clearance, and most possibly that is a past or chronic infection. What if you have a case with an antibody positive but without a RIBA? Without a RIBA, so that means this is a false positive, because if you really have an antibody to the hepatitis C virus, RIBA should be positive. Okay, it's a confirmatory test. If you have a positive HCV and indeterminate, that requires further study. Okay, So the treatment for hepatitis C also uses antivirals. And again, if you say decreasing levels of RNA, that is a positive virologic response. Okay? The RNA levels is the most important predictor of treatment response. Okay? The most resistant type of Hep C virus is the genotype 1. And also one thing, why don't we have vaccination against hepatitis C? It's because of the mutation, okay? Mutation of the hepatitis C virus. Okay, so genotyping basis, you can have molecular assays. Okay, we're familiar with this. Maybe we've heard of this from biochem. Then serologic, that means the antibodies, okay, and the antigens. And RNA detection to the following, okay. And qualitative and quantitative, okay. But take note, in measuring the RNA of the hepatitis C virus, it does not reflect on the degree of the hepatitis and the fibrosis. Why? We need the liver biopsy. So in the beginning, no, in hepatitis C, first you need a liver biopsy in order to tell us, in order to decide if the patient needs treatment and what treatment. So liver biopsy. But for the monitoring of treatment response, or if to check if the patient is responding to treatment, then check for the RNA. Therefore, most clinicians continue to rely on liver biopsy for the severity of the liver disease, predict diagnosis, and decide whether to treat. Hep E is an RNA virus, fecal oral. We knew that, and it's very common among travelers, okay, and among pregnant women. Very fatal among pregnant women. Okay, the same route, fecal oral, same as hepatitis A. It's a Hep E virus, and again, it's between we have the HEV RNA, okay, and the antibodies, okay, not very significant, okay. For hepatitis G, it is very much similar to hepatitis C because of the route, okay, but this is a very rare virus. And other viruses as well that can cause hepatitis, okay, but these can just be mentioned in passing. This is a tabulation of the different hepatitis viruses and how it behaves, okay, and where we can what are the associated conditions or associated characteristics, okay, you can just read on them. And this is the pattern of the serological timeline of hepatitis B infection. And if there are no questions, have a great day.